otro episodio más de Parálisis Cerebral Respuestas. Este episodio va a ser en inglés, pero no se preocupen. Si quieren ver los subtítulos en español, pueden ver el episodio en YouTube y ahí le pueden poner subtítulos en español. Welcome to another episode of Cerebral Palsy Answers. This episode, as I said in Spanish, will be in English. And I'm very, very happy to do this episode and very proud of the person that I'm going to interview. There are people that come into our lives unassumingly without that you have no idea how much impact they're going to have in your life. As you all know, most of you know that have been listening to the podcast in the last couple of weeks and the last couple of months, I had the opportunity of going to Germany, Heidelberg, for the European Academy of Developmental Medicine and Childhood Disability Conference in Heidelberg, Germany recently. And that's where I met my guest for today. I met her while I was running and got into a train while I was struggling with my luggage. And she has no idea how much she's impacted my life and how proud I am of her and how happy I am that the universe, that life has allowed me to meet her. Yeah, and without further ado, my guest. I could go on, but I'm just so happy. And please, my friend, correct me if I say your name wrong. Selamenensh Tsige Legas.
Tsige Legas. Yes, that's
Tsige Legas.
our hard one. Yes.
Muy bien. Thank you, my friend. Selamenesh is a developmental pediatrician. She's the first from Ethiopia, which is amazing. It's in itself. She is also an assistant professor at Western University. And you could see her curriculum online is just incredible. And like I said, I'm extremely proud and happy and grateful that I get to meet her. And in today, she had the opportunity, she presented on like 10 different topics during the conference in Heidelberg, and we barely saw each other like running across the conference. I mean, we saw each other the first time while we were getting to Heidelberg and waiting for a taxi and struggling with our luggage. But we came up with the idea that we'll do a two-person conference, one for adults and one for children. I got the adults and she's got the children. Because our Uber was taking so long to get to the station. It was like 15 minutes. So anyway, I'm just so excited. You can tell. My guest for today, I'll let you introduce yourself, my friend, and talk about one of the many topics that you presented on in Heidelberg, one of the 10, I think, which is the implementation of the HINE in low to middle income resource settings, correct?
That is correct, yes. So it is an honor to be with you, Azu, and you have impacted my work and also my stay in Heidelberg in so many different ways. I was really motivated by your opening speech and you leading the session in Heidelberg as well. So my presentation was on integrating the Hammersmith Infant Neurologic Examination tool for early detection of young children with cerebral palsy, and was more focused on presenting lessons learned from low-income setup area, particularly my home country, Ethiopia.
Yes, that is correct. And one of the reasons why I really wanted to talk about this and in particular with you is, before obviously doing the interview, and I always do research, right? And I pulled out some statistics that for me were very eye-opening, right? And I'll share with you. And these everything that I share, I must say, everything that I share in terms of statistics comes from papers that have been published in medical journals and things. So these are statistics that are coming from the paper called Cerebral Palsy and Developmental Intellectual Disability in Children Younger than 5 years, findings from the GBD WHO Rehabilitation Database of 2019. And the GBD is the Global Burden of Disease Study and World Health Organization. And this paper sets out to analyze the available global and regional estimates for the prevalence of CP. And according to this paper, globally, there, and let's just say, I reiterate, this was published in 2019. Globally, there are 8.1 million children under 5 years that are estimated to have CP, right? And over 98% of those children reside in low income and middle income countries. So what they call LMICs, right? The African region recorded the highest prevalence of CP with 1.6%. Southeast Asia region had the highest prevalence of intellectual disability, which was also something that was mentioned in this paper. And they also included the top 10 countries where primarily CP had its prevalence. So the top 10 low to middle income countries, which were, if you're interested in lists, which I am, I love lists, India, number 1, China, Pakistan, Nigeria, Bangladesh, Ethiopia, the Democratic Republic of Congo, Brazil, Tanzania, and Indonesia. So this is why it's so important to talk about topics like what we're going to talk today, because the grand majority of children worldwide with CP live in low to middle income countries, and they do not have access to MRIs and cranial ultrasounds and other tools. So I really, I want to start off by asking, what exactly is the HINE? Just a very basic question. It sounds way too basic, but maybe a lot of us, might not know what the HINE tool is, and why in particular did you decide to pick that one over the GMAs or the MRIs or any other tools available?
Yeah, that's a great question, and I would add into the data that you presented, Azu, that most of those data, I would say, especially the one I can speak like in my continent as well, like including the whole of Africa, and most importantly from Ethiopia, we do not have national data. So you can imagine that it could be a fair underestimation of what the prevalence might look like. And the global burden of disease just compiles the data that are available within each country. So when looking into any childhood onset disability, including cerebral palsy, one thing that really bugs me in my mind is that these children, especially in low resource setup areas, they present very late to the clinical setup. And when they have like overt motor symptoms or have severe functional impairment, or most of the time and most frequently, they present with clinical complications that are worrying parents. So say if they have frequent seizures, or they stopped eating, or they have severe malnutrition, those are the common presentations that we see in our setup and in most low resource setup areas. So when I was in Ethiopia as well, I led one of the contemporary researches done in CP, and as I told you, we don't have a national data, but this study was done in the major tertiary hospital in the capital of Ethiopia, and that's where we have like the highest pool of children with CP, as the hospital receives referral from different regions of the country. So with the study that I did during that time, we noted that children with CP at presentation, and when we overall analyzed the data, the age of presentation was on average around 5 years of age. And that is very far away from what is recommended in the international clinical practice guidelines and what our colleagues and peers are currently doing in most developed setup. So that is very far away from the recommendation, which is less than 12 months of age. And that was one of the reasons that triggered me to think, oh, this is a big gap that we have identified here, and we need an early identification. But how early can we detect CP, and how can we do that? And there has been many ongoing studies in that area. That is a well-studied field in terms of accurate diagnosis and early intervention. And when I joined my fellowship study in Holland Bloor Kids Rehabilitation Hospital in Toronto, Canada, I learned about the Hammersmith Infant Neurologic Examination tool. Immediately when I learned the application and how it can be interpreted and how helpful it could be in the identification of high probability of cerebral palsy, I became a big fan of it. And one of my mentors, my biggest mentor, Dr. Darcy Pelling, has done a lot of work with the HINE, and she's a big fan of the HINE. So I'm borrowing the word that she used, and I became a big fan of it as well. And I see that they have been trying to implement it to be used by general practitioners all over Canada. And I say this is easily interpretable. It's all the neurologic examination techniques that we all learn as a physician. We all know how to do it. The only different thing the HINE would do is it kind of summarizes it beautifully and makes it structured so that the neurologic examination that you do, and we all do it when we do this, when we evaluate patients, but it just helps us score those neurologic examinations. So it is a very simple tool. There is a high inter-rater reliability. It is well studied, and a HINE done by a student. And if you compare it by a high-level expert like myself, a developmental pediatrician, the score would be very comparable. So it doesn't matter who does it. It can easily be applied. It is accessible to all clinicians. It is open access. And it also helps us improve our neurological examination skill because it reminds of you the things you need to look at in a child when you are doing your physical examination. And the prognostic information that we get from doing the HINE is very invaluable. It's of very high value. It can with a high sensitivity value, it can identify a high probability of CP. So with more than 90% certainty, sensitivity, and specificity, we can easily say does the child have a high probability of CP, especially those children that present with identified risk factors. And it also gives you an opportunity to sequentially follow the child. So you can compare the HINE score at 2 months with the HINE score at 4 months, 6 months, 9 months of the same child, and you can see the progressive gains or the motor presentations of the child. So overall, because it's very simple, affordable, can easily be applied, everyone has the skill to do it, and we just need to learn how to score it. I found it being a very applicable tool in low resource setup area.
Well, first of all, let me congratulate you for doing this study and this project in your own country, because as you said, and as I was doing the research for this episode, I realized that there's a huge lack of literature about the tools used in low-income countries as opposed to high-income countries. And the research that is available about the tools comes from high-income countries, right? And that is not, I don't think that makes sense Why? Because the realities are very different, right? And the healthcare infrastructure is completely different. The access to prenatal care is very different. So the reasons why children might have CP in high income countries are very different than the reasons why children might have CP in low income countries, because the parents don't have access to prenatal care, right? And even if you set up a clinic in like a low income or middle income setting, doesn't make sense. You have to think of so many things. So thank you for leading the way in that sense, because you truly, there really is a huge lack of research of what is available in tools that can be used in low income countries. So you truly are, you and your team are leading the way. So thank you for that. What and just so that I have it clear, the HINE is like a list of 24 items that doctors and clinicians use to test like muscle tone and spasticity. Can the HINE be done through Zoom? Like how did you because you were in Canada, right? And you were training clinicians in Addis Ababa University in Ethiopia. How did you do that? Please tell us, how was this process, right? Of training clinicians and doctors via Zoom, or how did you do this?
Yeah, thank you for that question, Azu. And you are right, just to rewind a little bit back on your comment on the presentation of CP in the different setup areas. That is very valid and a fair comment that you made. And I would say like one of the very influential clinical practice guideline, which was developed by Iona Novak and the team on early accurate diagnosis and early intervention in CP, was looking through all the available tools and then what else can be done in low resource setup areas versus high resource setup area. And you are right, the risk factors are also very different. So from the study we did in Ethiopia, we have, and also many African setups, we know that the most common risk factors are related to infections and hypoxia or deprivation of oxygen to the brain, and birth injuries and things like that, which are very easily controlled risk factors in most developed setup areas. So before going into explaining the HINE, what I wanted to highlight to our listeners here is that in this early diagnosis and early identification of CP algorithm, which was presented in this particular paper that I mentioned, they categorize it between those infants with detectable risk factors versus those infants whose risk factors are not identified. And the HINE is mentioned in both categories, as well as in the age groups below 5 months of age and in the age groups above 5 months of age. And there are other tools. There are many other tools, including the MRI and other motor assessment tools that we do use. But those motor assessment tools would need experience, practice, and also availability and being open access, right? Those are big challenges to access in low resource setup areas. And we know MRI is also not affordable to many of our families. So in this context, when we overall look at the available tools, then the HINE stands out to be the most reliable because it depends on the skill of the clinician and the one who's following the child. So that being said, you are right, the HINE has 26 items in it, and it's basically a component of normal neurologic examination that every physician would do when seeing a patient, a child, or evaluating a child. So it assesses the cranial nerves. That means like the nerves that control like most of the functions or the muscle functions, say, could be in our face, eyes, hearing, and as well as like other muscle components. And it looks at the posture of the child, how the child is sitting, maintaining sitting, standing position, what is the shape of the hand, the legs, what does the overall posture of the child look like. Also look at the quantity and quality of movement of the child. Then we assess tone, the stiffness, how stiff is the child, or do they have low tone, and what does the reflex look like. So these are all examinations that your physician, a general practitioner or pediatrician, do it with your children. So what the HINE really do is it helps us score these examinations from the highest score of 3, which is the typical or optimal finding that we expect in a child, to a lower score of 0, which is a high risk or more into the high probability of CP category. Then once you do the HINE score, it also allows us to standardize the score as per the gestational age of the child. So a child born term and a child born preterm, the way the final score will be interpreted will be different. So because we know a preterm child has higher risk of CP and higher predisposition, so we take into the consideration the preterm age and we correct for their gestational age. And these are things we basically learn in medical school, and everybody knows how to do this. It just in a way organizing it in your brain and applying the scores to give you more information about the tone and posture of the child and overall neurologic presentation of the child. And luckily, we do have a HINE scoring aid, which was developed by Dr. Fellings, who I mentioned as my greatest mentor. And the scoring aid helps you plot the score and know at which level the child is functioning at, or presenting in terms of their motor presentation. So one thing I want to emphasize here is the HINE tool is not a diagnostic tool. So it can tell us about the motor presentation of the child, and it can give us a really good information about the neurologic presentation of the child. But we do not make a diagnosis of CP based on the HINE score only. So as you know, CP is a very heterogeneous description of motor presentation. And so to make a diagnosis of CP, there needs to be your overall clinical input along with the HINE. So it's not diagnostic, we do not make a diagnosis, but it does help us understand the probability of CP in a child who presents with risk factors associated to CP.
Okay, that's very interesting. So it's not a diagnostic test. It is sort of a supplement in addition
Yes.
to, and I imagine, and you mentioned this in your presentation, is that I imagine that based on the score of the HINE, even though it's not a diagnostic test, it allows for clinicians to refer parents to whatever available resources they might need if they identify CP, right? So that's why it's so important that the earlier the better, because then, if you do this exam, the HINE from, I don't know, from 0 to 2, then that, in my opinion, or I would think that would allow the parent to have access to resources and to therapy more focused towards CP. And that's why it's so important. Now, going back to your and please correct me if my observation was wrong, but going back to your project and implementing this in particular in Ethiopia, what challenges were present for you? You mentioned in a blog that you sent me that a lot of clinicians perhaps didn't know about the HINE. And then, accessibility and distance, and what were the challenges that were present as you were trying to implement or, introduce the HINE in your country?
Yeah. So yeah, the first challenge would be that nobody knew about the HINE, so we had to introduce it. I learned about it when I did my fellowship when I came here, and so we had to introduce what the HAMERS means, infant neurologic examination in tool is, and then how do you use the tool. You don't use it as a diagnostic tool, but it helps you formulate the overall assessment of the child. And so we selected out the major tertiary hospital, which I was working in and where I started the developmental clinic previously. So in that hospital, we know that from the previous research we did, and then on a routine audits, it's a highly burdened hospital where we see like over 500,000 people a year. And we have a pediatric neurologic clinic where there is a highest burden of cerebral palsy. 20 to 30% of the children coming to the neurology clinic had CP. And there is a high-risk infantile clinic which follows like around 250 children each month. And these are children who have some kind of risk factor, could be prenatally or during birth or after birth. So we said this would be great targets to target the high-risk infantile clinic as well as the neurology and developmental clinic where I had been working previously as well. So what we did initially was introduce the HINE. So we had, without saying all the proposals, writing up the project and everything goes in here. And then following that, what we did was introduce the Hammersmith infant neurologic examination tool to the whole pediatrics department team in Ethiopia. So we did that virtually. So as you said, I was in Canada. The whole team is in Ethiopia. So we selected these target clinics to be the neurology clinic, developmental clinic, and the high-risk infantile clinic. We reached out to colleagues who lead this clinic, the staff in Ethiopia, and we organized a working team, so the research team, and hopefully this will be soon published and will be available to everyone. So the research team had the heads of the pediatric neurologists, pediatric neonatologist from Ethiopia, my colleague who leads the developmental pediatrics clinic, and then all my mentors at the University of Toronto, including Dr. Felix. And we made a good case why the HINE is important. Like we said, in addition to it helping with the diagnosis of CP, it can also tell you the function of the child. So say if you get by the end a HINE score less than 40, it is equivalent to a JMFCS level 3 to 5. So we know that the child have a less chance of ambulation with the lowest HINE score, and it tells you, it can also help you classify the phenotype based on the score. It helps you imagine what the phenotype of CP would be if that child clinically fulfills the diagnostic criteria for CP. So we followed the knowledge to action cycle. So that is a framework which helps, which is a knowledge translation framework, and helps you organize your thought and formulate in a way how to implement the knowledge, which is the HINE, into practice. So we mapped it in the knowledge to action framework and mapped what we should do at each step. So the first step was introducing the HINE and identifying that there is a problem of lack of early detection of CP. And luckily we have the Mackey's Press, which has the Hammersmith's neurologic examination training videos, which are openly accessible for low resource setup areas. So all you have to do is register, and then it does pick on your area of residence, gives you full access without payment if you are from low resource setup area.
Mm-hmm.
So once we identified those educational packages which would be important, then we introduced to the whole team. We used the pediatrics department grand round at Tukurambasa Specialized Hospital, and my colleagues from University of Toronto, Dr. Failings, Dr. Makino, and Dr. Banihani, and myself, we introduced what the tool is to the whole team. And then after that would not be enough because the team doesn't have enough experience to practice with the HINE. So what I did was, as the lead of the project, I started to train the pediatric residents rotating through these 3 clinics that we picked out every month. So every month, a number of residents will rotate through the clinics, and every month it's a new batch of residents. So every month I would do it virtually. Will use one of the dolls of my daughter, show how to do the HINE assessment. I will use videos, and I will use like pictures to represent, and we will practice online how to score. And we had a separate training for the staff leading the clinics, so the staffs could help them in practice. And fortunately, one of my colleagues had a chance to join Pisa University for a 1-week research training, and they were focusing on the HINE by that time. And so she got the full training and practice with the team, which was led by Iona Novak. So that was a great opportunity for us. But all to say, it is possible to teach the HINE virtually because everyone knows these physical examinations. What we are teaching them is to the techniques, how to apply like each examination techniques, and also how to score the child. And it's always helpful when you start practicing the HINE to do it with a colleague, because then you can cross-check each other, you can score at the same time, compare your scores, and do it like that. So the theme in Ethiopia was in practice assisting the residents after I give the training. And I will come to the question of the challenge that you mentioned, and this would be highly relatable for many low resource setup areas, because one of the biggest challenges was I trained them on the HINE virtually. So to access virtually, we need internet connection. So that was one of the biggest challenges in Ethiopia, and access to internet was very difficult. So the team in Ethiopia and my colleagues, they had to use their own personal data and connect the computers to their phone. And then we devised a mechanism for all the trainees to be in one classroom. So then they can share like one internet source. And then I was doing the training that way. So it's nice because it feels like a classroom. You can see all the residents in the classroom, and they can also talk to each other and present their questions. The other challenge was I am in Canada, and Ethiopia is 8 or 7 hours, depending on the season, ahead of Canada. So that was the biggest challenge. So the first training that I told you that we did on the introduction of the HINE, myself and my mentor, Dr. Failings, we had to do it at 1 a.m. in Canada, in Toronto time. And that was morning for the Ethiopian team. So there was no other way we could have met the whole team in Ethiopia. So, and then there were subsequent challenges. So we trained them on the HINE, and they have to have the HINE scoring sheet at hand, but there was no printer. So they couldn't access the paper easily. So paper would look like a funny challenge, right? When you are living in very resourceful areas, but and in our setup, we don't have printer, and even accessing the papers could be very difficult. So we had to buy printer for the clinics, and that was fortunately done through the funding again, through the work of Dr. Failings, and we purchased a printer, and they had it accessible in clinic, and that was, I think, they are still using it. So I'm happy that we were able to provide that. And subsequently, I had to follow with the residents how they are doing, if they have any questions. So again, to avoid the internet disruptions, we had to use Telegram channel. So we had to be more innovative and use the social media for a teaching purpose, which was one of the good things we learned from this communication as well. And
Wow.
finally, I would just include one more thing, Azu.
Yeah.
Personally, I had, when we started this trainings, was, I had my third child. So I was like, she was very little. I have to breastfeed. So you know, all the stories a mother has to go through. So and getting up to do these trainings in the middle of the night while having a unit at home was another big challenge as well.
Wow, that's amazing. Oh my goodness. And I didn't ask you, my friend, when did you make these, when were these trainings done? What year?
So we started sometime. I have to. So sometime in December, and then we did it subsequently for 7 months. I'm not sure. I have to look back as well about the exact time and confirm that with you.
Was it December of last year, or
No,
the year
this is
before?
in 20. So I think we started December 2022, and then we do it for 7 months
Ah, okay.
subsequently.
Oh, wow.
Yes.
So it was fairly recently. Yes. I mean, 2022, that's,
Or
yeah.
it could be 2023. I have to look.
Yeah, I mean,
I,
yes, no worries, but regardless, it's fairly recent when you did this with this project,
yes.
this collaboration. Um, it is amazing, and thank you for sharing those realities that again you don't read in papers, right? Of high income countries, like access to a printer, access to paper, access to the internet. These are the realities that clinicians and doctors, or not even, as you mentioned, the whole reason of doing this project is introducing them to the HINE, right? That they didn't know. These are the realities of of low to middle income countries, and you know, as I'm reading research and reading papers, these are the countries where not only the most children with CP live, but where the incidence of having CP occurs, right? And so it's so important. The work that you're doing is so important. Thank you for that, and thank you again for sharing those challenges that need to be heard, that need to be seen, that you know don't necessarily are not seen in high income countries, right? So what difference did you see? I mean, again, this might be an obvious question, but what difference did you see from that moment, that, you know, from those subsequent 7 months that this was going on? What difference did you see automatically after you introduced the HINE and you trained clinicians and doctors in Ethiopia? I mean, you mentioned something very beautiful in your presentation, and you mentioned a quote from another doctor in Ethiopia, and it said something like he felt, he or she, I'm not sure, but felt that they were they felt hopeless, and that they felt sort of finally they're able to give to the community, or have the knowledge to help parents, something along those lines. And I'm sorry if I'm butchering the quote, but I want you to share that. That was so beautiful to me. Please do share about this doctor who you mentioned in
Yeah.
your, and I'm sure there were so many more in your presentation, but what were the subsequent effects of introducing the HINE in
Yeah.
Ethiopia after this?
Yeah, that is the piece I love to talk about. So we I trained 54, a total of 54 residents during that 7 rounds of training. And yeah, I can confirm with you, I was just looking up. We started in December 2022 and had to finish like in 2023. And so there was this sense of the feeling of worthlessness. That's what the resident said, a feeling of worthlessness when working with families and children with childhood onset disabilities, because and especially I do share that highly because I was all my interest in developmental pediatrics and childhood disability started when I was working in the neurology clinic. And I meet all these families, parents of children with CP. They come to the clinic, we sit down, and it's a neurology clinic. You're supposed to do everything very fast, and everyone knows this in low resource setup areas. You have to see many patients, and we focus on like things which are treatable, like seizure, or anything that we can give medication to. And I felt there was a high disconnection between what the families and the children wanted to talk about and what I was able to offer to them. So most of the families, to give you a little bit of context, and this would our listeners in low resource setup area would highly relate to as well, is that most families in our setup, the children are taken care by the mothers, and usually the mothers are divorced, or they're not divorced, but the husbands usually leave them. When they have a child with disability, there is a high discrimination in the society, and they think of them as a consequence that was sent to the family because they have committed some kind of sin. And that creates a big discrimination, and that's one of the reasons we don't see these children earlier in our clinics. And when they do come, there is a lot of burden in the family. The children that I have been seeing, as though they can't, they have severe functional impairments. They will not be able to walk. Mom has to carry them on their back. And the mother tells me how her husband left her, how the society is treating her, how this child is not able to communicate what they need, and she don't know what to do with them. And all we want to talk about is seizure medication. That was a big disconnection. And I couldn't continue to do that. So I had to take more time to talk to this family. And that's when one of my mentors recognized that I am interested in disability care and told me about the field of developmental pediatrics. I started to learn about it and reach out to people. So this resident, what she is, it's a girl resident, I remember. What she is talking about is this feeling of worthlessness that we do feel when working in the clinics, that our focus need to be shifted in a certain way. So she says, and I have the quote here in front of me: "Thank you so much for the training. It was informative. And you address very important concern from many residents, the question of we are not doing anything for CP patient and the feeling of worthlessness." And I highly relate with this comment because that is how I felt, and that is how many of my colleagues felt when working with children and families with CP. Yeah. So
Ooh,
I see I made you emotional as well. I'm sorry. I
yeah,
know
let
this
me take a
is.
moment, because that is a reality that is shared, as you said, in low to middle income countries. And also the fact is that, well, two things. The I'll make an observation based on comments that I've heard from other doctors in Latin America, and then I'll make a personal comment, a very personal comment, which, yeah. Anyway, in Latin America, talking to Central and Latin America, well, all of it, it's all the same. Talking to doctors, they see much more severe and complex cases. You know, they see more of the 4s and the 5s, right, of children with CP. They're detecting CP earlier. However, they're seeing the most complex cases, the 4s and the 5s. So again, what we see in Europe, in the US, in Canada, in Australia, doesn't necessarily translate to the realities, as you mentioned, of Africa, Latin America, and Asia as well. So yes, I'm sure a lot of the people who are listening, clinicians and doctors in low to middle income countries can relate to what you mentioned. We're going towards the end of the interview, my friend. Unfortunately, I wish I could just keep going because you are a wealth of knowledge, and I'm so proud of you, of everything that you do.
Yeah.
But getting back to the interview, go ahead. I'm sorry.
I also let's come back to the good results. Then will
Yes.
take us out of this emotion. Yeah.
Yes, please. Otherwise, I'm going to start crying and talking about other things. Anyway, going back to the interview.
Yes. So the results were really a surprise for us as well. So overall, 117 infants. So you can use the HINE starting 2 months of age. So we did for those infants between 3 months to 2 years of age, and that's up to what the HINE would go. Overall, they evaluated 117 infants in the high-risk infantile clinic, neurology clinic, and developmental clinic. And of those, with the documented risk factors, possible risk factors for CP, we identified 98 children. And we just tried to see like the different categories of possible risk factors. And as I mentioned initially, the most common was neonatal encephalopathy or oxygen deprivation in relation to birth events, followed by jaundice and preterm delivery and sepsis were the most common things. But then what we were very excited to see was we tried to see what if this intervention has brought down the age of diagnosis for CP, because some of the children were really diagnosed with CP based on the HINE and also clinical evaluations. So we had a total of 35 children who scored at the highest probability of CP, and among those, almost 50% were given a diagnosis of CP. And when we looked at the age, we found out that the mean age at diagnosis and referral was 10.6 months. So that was a big change from what we had previously, around 5 years of age. So that was a really exciting finding for us, and we were so happy. It really motivated us that yes, so HINE is the way. Let's continue to implement it in our clinics and use our clinical skill to make a diagnosis as well. So the main part we are focusing currently is on this sustaining the knowledge use. So this 54 residents, they are trained, but there are other 54 residents coming through those clinics. So continuing to train these residents, and the staff is capable now because they already have enough practice with it and they know what to do with it. And subsequently sustaining the knowledge to use is the biggest piece of the work. So as we met you and me as well, you met me when I was disseminating the knowledge in an international conference. So had been doing that multiple times. The first few conferences I was going with my little daughter because she was still breastfeeding. I would breastfeed in the middle of the conference and we do the presentations together. And the team in Ethiopia has integrated it into the HINE into the clinical practice, and is part of the residents' examination as well, because exams motivate students to continue to learn about things. So that those are some of the reinforcements we are using to continue the work. And the team in Ethiopia, and also my colleague who runs the Developmental Pediatrics Clinic, has been monitoring these residents and sustaining the knowledge use and disseminating it nationally as well. So way forward would be we are happy to support any low resource setup area interested to do the same work. I'm happy to be connected with anyone who wants to do this work. And that's what I have been doing. I have been supporting interested regions in Africa, outside of Africa, who are interested to implement this. And so it's all about sustaining and disseminating the knowledge at this point.
So two things. You have that is amazing that you saw firsthand the changes and the positive impact of the implementation of the HINE right away from 5.6 years, I believe, to 10 months. You said that is amazing. That is a huge change. And then two, this based on those results, this has motivated the team in Ethiopia in particular to keep going and to create a pipeline sort of to continue to spread the knowledge and disseminate the knowledge that you got from this project. So my last two questions, my friend, are what advice would you give to other countries or clinics in similar limited resource settings? And maybe you just mentioned it as well, but so what advice would you give to other countries or clinics in similar resource limited settings hoping to implement the HINE?
Yeah. So because we're talking about the HINE, I made my talk very specific to the HINE implementation, but of course there is a question of what then, right? So after we make an early diagnosis, then what do we do about it? So the next steps will be early intervention and think about more plausible family-centered, low resource interventions that we can apply in different setups. And that is what we are thinking about currently. And there is very amazing works done all over the world. And I would say low resource setup areas are very innovative, and we put our heads together, we know what to do using like very locally available resources. So my message to other low resource setup areas is that this is specifically to the HINE, this is a tool. We all as clinicians know how to do the examinations. It's not complicated. All we have to learn about is how to score it and how to interpret the results. So I would encourage all clinicians to start using the HINE and see how it helps them identify those motor differences in those young infants. And it does really help formulate your clinical assessment as well. So I would really, really encourage everybody to look into the HINE. And it's very easy. You can self-train as well. You can access the self-training videos online. It is interpreted in few languages as well and being implemented. So I would encourage everyone to look into this. And I would say at the moment that with respect to clinical skills, the HINE is the way.
Perfect. And my last question, actually, my friend, is how do you see this world, this work, I'm sorry, not this world, this work, how do you see this work evolving in the next 5 to 10 years in Ethiopia and beyond? What do you hope to see?
Yeah, so my hope is we do like basic foundational studies like this and an implementation of tools so that we can early identify children. But the main purpose is the early intervention piece. And so my hope for Ethiopia and including other low resource setup areas and whole of Africa would be to be able to apply those early intervention techniques, which are really accessible and less demanding ones. We do not have to look into the ones which are being done in high developed areas, because those look very high for our reach, and it may feel like demotivating when you look that, well, I can't afford this, I need this high-tech technology, I can't do that. But there are really very good programs which are implemented in many centers. One of the programs, which is led by my greatest mentor, Professor Hans Forsberg, is the Akwenda program, which is implemented in Uganda. So such programs would be the way to go. And we really have to look into innovative and low demanding resources to apply in our resource setup areas. And I tell you, those come from families most of the time. And we learn a lot from the families and the children we work with. And so my biggest advice would be talk to the families, listen to them, and see what they are doing, what is working for them, and try to change that in a way that is clinically applicable as well.
Yeah, absolutely. Listening to families is so important. I know that there are a lot of, well, one of my most recent episodes, and we're getting towards the end, but one of my most recent episodes was actually about the CP registries going on in Latin America, right? And in Argentina, Brazil, Colombia, and Mexico. And I don't know, are there any going on in Ethiopia? Because I would imagine that in the sequence, if we're thinking linearly, right? I would imagine that if you implement the HINE, let's say Ethiopia, if you manage to create this pipeline and you start implementing the HINE and you start, identifying more and more cases of children with CP, then that would increase the numbers and to actual percentages of children who have CP in Ethiopia and beyond, right? And then that would help create CP registries and actual numbers. And unfortunately, we know, or I think that if it is only through numbers that people start noticing things, right? And they start making a change of things. So I would imagine that this is going to, your implementation of the HINE in Ethiopia and beyond is going to help create CP registries and real actual numbers, and not based on studies made by high income countries, right? So thank you for everything you do. You're leading the way, truly.
Thank you so much, Azo. And that is really funny you raised the CP registry, because I was just in a meeting with colleagues and talking about the international CP registry in low and middle income countries. We just had, I just recently, like over last week, and this happened in Heidelberg, we discussed that Ethiopia has to be included in the CP registry as well, and include multiple centers. So I had made these connections, and we are hopeful that this work will go on and will be part of the international CP registries as well. Thank you so much.
Oh my God, that makes me so happy. Yes. Thank you, my friend. Thank you for everything that you do, for leading the way, even though that there is no, you started off with really little information, and it began from this sort of sense of worthlessness, as you said, a disconnection between, you wanted to do more because you saw the realities of the families, and you identified that was a feeling shared by a lot of your colleagues around you. So thank you so much for this amazing work. And I'm sure a lot of what you said translates to not only Africa, but so many other continents, well, Africa, Asia and Latin America, low to middle income settings. So thank you for sharing your knowledge. Thank you for sharing all your findings and for all the work you do again. And as I mentioned, for me, words are not enough to express the deep admiration I feel for you And I am truly grateful that life has allowed me to cross paths with you because you are a beautiful human being. Thank you.
You are a beautiful human being as well, Azu, and I'm very happy that you invited me here, and thank you for all the respect you show me. Thank you so much.
Absolutely, my friend. Thank you so much. Well, for those of you who have or who are listening around the world, this is it. We've reached the end of this episode, but I'm sure this will be the first of many episodes I get to interview my friend. So, my friend, you won't miss me too much because we will talk again.
Esto es todo por hoy. Gracias por acompañarme en otro episodio más de Parálisis Cerebral Respuestas. Si tienes alguna pregunta sobre la parálisis cerebral en español o inglés, por favor envíala a mi sitio web www.azucenagarcia.com. Gracias.